So what are we focusing on? I mentioned rare diseases. Well, there are over 7,000 rare diseases, and really it's a misnomer because it's affecting 30 million US persons and over 300 million worldwide. Over 85% are genetic based, 75% affect children, 30% of those children will die before the age of 5. Many have neurological disorders, and as I said, the failure rate of drug development is over 90%. Less than 1% of these children or these patients will have a treatment, and most physicians will report that they have difficulty diagnosing and managing these patients. They have very little resources for taking care of these patients, and they find very little help from professional organizations who advocate for these patients. And patients often report greater delay in diagnosis, more depression, and greater work and financial hardships. So what we've done is, to show proof of principle, we took 2 children with a disease called Niemann-Pick type C. And these children came to the Institute looking for a treatment. So what we did is we told them, why don't you take stem cells from your children and see if you can use a existing drug that's already been out there and position it to see if it can cure your children's stem cells. And if it could, maybe if given to your children, it may affect a clinical benefit. So we were the first to create adult stem cell from patients with a rare disease. So they came out, flew out to Iowa. We harvested some fat from them, and these children have an inborn error in the inability to metabolize cholesterol. So cholesterol accumulates, it causes cell death, and particularly the neurological cells are the most vulnerable. Interestingly, it's already been shown that these patients, their genetic defect is actually protective against Ebola. So it's actually an important model for developing drugs against Ebola. So what we found is that working with them, working with an academic organization, and working with NIH, we discovered that if you took a drug called cyclodextron and you administered it to their kids' cells, it basically reduced and eliminated the high cholesterol that built into their cells. So the children 2 years later went off to get compassionate approval from the FDA to receive that drug. And the 2 siblings, the older sibling had already established the disease as an adolescent. And typically in the natural history, a few years later, they would die during their adolescence. In fact, it's the most common cause of juvenile dementia. So the treatment actually started to arrest the older sibling's disease. And the younger sibling has received this drug and it has prevented the onset of that disease. So this shows that, within a 2-year turnaround, it validated that by taking stem cells from a patient's disease, it can be used as a surrogate, sort of a disease-in-a-dish model, to screen a drug that could have a therapeutic value. So that's the rationale of why use stem cell as a tool. Let me talk about cancer a little bit. It represents less than 1% of the patient population. It consumes 10% of the cost. 22% of the cancer patients receive chemotherapy. Chemotherapy patients generate 4 times more cost than non-chemotherapy patients. And according to insurance statistics in 2007, the average cost for treating a patient with cancer with chemotherapy, all costs considered, is over $100,000 a year. And so this is a big financial hardship for cancer patients. And so one of the challenges is that insurance companies are often looking for ways to reduce their costs that they're outlaying for a patient with cancer. So oftentimes they'll insist that they use old, cheaper drugs rather than more established, newer drugs that might be out there, strictly based on cost. So we currently spend $26 billion a year on chemotherapy, but only about a third of that is really achieving a significant complete cure. There's a 92% drug development failure rate. So obviously, one of the issues that cancer patients are concerned about when they're receiving chemotherapy is what is the efficacy and the side effects about receiving chemotherapy. They want to know, am I going to really benefit from chemotherapy, and is it going to be worth the side effects and the cost that I'm going to have to go through? So we often give chemotherapy empirically or based on the average patient determined by a clinical trial. There is this issue called cancer stem cells. So cancer stem cells, I mentioned earlier, are clinically important. These stem cells are, you might think of as the ancestors of the tumor. So they represent a very small percentage of the tumor, but they give rise to all their subsequent tumor cells. And they are resistant to chemotherapy, radiation. They are more likely to metastasize, and they're more likely reason for cancer to relapse. So with this background, this is our research and treatment logistic process. So what we do is, in the center, we work with clinicians. We obtain a variety of different disease tissue samples, either normal or disease, and either through radiological CT-guided procedures, surgical procedures, or from diagnostic procedures. And we take tissue and we also collect clinical data on those patients. We ship it, we process it, we isolate, purify, and develop these cancer cells or stem cell lines. And then we work on trying to screen those cell lines with drugs that we have access to or partner with other entities to find what are the lead best agents that could be then reintroduced back with that information either to the patient, the doctor, or to the pharmaceutical industry. And this is basically our core expertise. So all of this has currently been done on the left, what we call under good laboratory practice. This is not something that can be approved for cell therapy, because cell therapy requires what's called good manufacturing practice, or GMP. This has to be transitioned from that environment, done in a laminar flow hood, to a clean room environment. So this is something that we are currently working towards. It's a major priority for us, because we have all of these variety stem cells in our repository. So just to give you an example, this is a stem cell from fat, and that we are, I have a movie here of how within a less than 24-hour period, you can see that these cells are starting to form neuron-like structures. So they're developing synapses, they're axons, and they're making connections with adjacent cells. Also, this is a protein block, basically showing in lane 1 and 2 a protein called tyrosine hydroxylase. This is the rate-limiting enzyme to make dopamine, which is important in Parkinson's disease. And in lane 3 and 4 is actually the same protein in these neuron-like cells. And you can see the amount of protein is going up for this enzyme, showing that there is an increased amount of dopamine production in those cells, which is an important implication for patients with Parkinson's disease. So lastly, to summarize, so in August, our institute basically went global because of the Ice Bucket Challenge. So as many of you know, the Ice Bucket went out to support ALS, and there were a number of grassroots blogs went out and said that the ALSA supported embryonic stem cell research. They actually are supporting a company that is using a fetal-derived brain cell for treating ALS, and this is from an aborted fetus, 8-week aborted fetus. And because of that, many in the Catholic Church were telling their diocese to not support the ALSA. And then they came back and said, support the John Paul II Medical Research Institute. And so that's when we got brought into the national and global attention. So we have, received funding from now 38 countries and support from all 50 states, basically from grassroots evangelicals and Catholics. This really comes down to the issue of the apostolic actions to Teo. Really, basically this was a term, a decree from the Vatican II, basically saying that it is really an obligation of the Catholic laity to do something to promote the magisterium. And I think that particularly those who are in the healthcare field and the scientific field, there is an obligation to advance medical research to support the culture. In summary, we have a foundation, a well-integrated healthcare, scientific, and business model. I think we are very poised to compete with the established research foundations out there, and that's really our competition, for all the reasons I already mentioned. There is need for ongoing support from the grassroots. We also are asking you to educate your networks, educate your churches, your friends, your family about us. If you happen to know someone who is a member of a Knight of Columbus council, of your local council, please let them know who we are, because the Knights of Columbus, one of their missions is to support pro-life missions. We also, money is just part of it. I don't know how many doctors are here in the audience, or how many nurses are here in the audience. You are very important to us too. You are interfacing in your daily life with patients. And those patients who have diseases, you have access to those patients that we need to interface with you to get to those patients. And so without that, there is no ability to develop the technology. So it's very important. You're in a very important position that you can help us, not just with funding, but also because you are also healthcare providers and have access to patients. So I thank you for your time, and also if you have any questions, I'll stick around, and if you want to come up to me